Third time is a charm. Okay, so let me just double check that everyone can see this. There should be a picture of a little kid in a yellow. Can everyone see just the presentation, Safely Reopening Schools?
Yeah.
Cool. So I'll speak just for maybe 30 minutes, and then I can answer questions if I know the answers to your questions that you have. And it might be that some of you will have questions or comments that you want to make to each other about how your schools are coping. I mean, I would also be very interested to find out some of the ways that you guys are tackling this issue. So the presentation today is partly based on a policy brief that I wrote, which is called COVID-19 and Schooling in South Africa, Who Should Go Back to School First? And it was reviewing the evidence that we have around the world of how does COVID-19 affect children and adults, and what does the science seem to say. So I'm going to touch on each of these key issues, these 5 key issues, because I think these are the main things. And I also mentioned some of the things related to the science of COVID-19. So the first one is that COVID-19 will be with us for the next 2 years. And that's even if a vaccine is found. So even if a vaccine is found tomorrow, vaccines take a long time to be distributed in the population, to be manufactured, bought, and for everyone to actually become vaccinated. So it's likely that if there was a vaccine, that it's only going to be around in about a year to 18 months, according to the World Health Organization. So the gist of this is that we have to learn to live. How do we get on with our lives in the midst of COVID-19? So we cannot keep schools closed for 2 years, and we cannot stop the spread of the virus entirely. We can only stop the intensity of the infections and deaths from COVID-19, what's called flattening the curve, which I'll mention in the next slide. The South African context at the moment, we have nearly 38,000 infections and nearly 800,000 deaths. And as everyone in this Zoom meeting will know, the Western Cape is the epicenter of what's happening in South Africa. We have the vast majority of cases that happened in South Africa. And that's for a number of reasons. The 2 leading explanations are, one, that there's many more tourist visits in Cape Town than in other parts of the world. And we know that it came from overseas. And also that the infection reached the townships and informal settlements and more dense populated groups or areas in Cape Town than it did in either Durban or Joburg. So there was a much faster spread. But the rest of the country is not immune, and they, unfortunately, they will also experience a surge, although our surge is likely to happen now in June, whereas their surge is likely to only happen in August. Schools are shut in most of the country. There was confusion around this, whether it was the 1st of June or the 8th of June, and children are going to go back to school incrementally. There's a big question mark about what happens nationally when the surge does come. Will schools shut again? And there's a lot of unknowns related to that. I want to emphasize that there are a lot of costs both to the national lockdown, which we've all experienced, as well as to school closures. So we're all familiar with learning losses, but also things like nutrition. Many children rely on the free school meal as part of their diet. When schools are closed, they no longer receive those. Immunizations, we've seen the rates of health-seeking behavior of parents decline significantly. TB testing has gone down by nearly 60%, as well as household income and employment. We're doing a survey now to measure that, but we anticipate that the effects of this are going to be quite severe. Sorry, Alta?
Sorry, carry on.
Okay. So I think that the safety of children, teachers, and parents, which is obviously one of the big concerns for principals, I want to show some evidence to show that this is primarily an adult's disease, not that children can't get infected. They do get infected, but that their immune systems seem to be much, much better able to contain the virus than adults, and particularly old adults, or older adults, I should say. So children's immune systems and the way that their bodies work mean that they only ever get mild symptoms. They almost never need to be hospitalized, and there are only a handful of deaths from COVID-19 around the world. And then lastly, how do we limit the spread of COVID-19? Things like hand washing and masks, how do we use them properly? How do small children use these types of things? And if their economy reopens, which much of it did on the 1st of June, what happens to children that are home alone, that haven't gone back to school? I think there are a lot of people that are, including myself, that are worried about those children. So firstly, we would have heard of flattening the curve. So that red curve that we can see here is and the y-axis is the number of cases. We can also think about it as being the number of deaths, but in this case, it's the number of cases. Obviously, deaths will be a much smaller percentage of those because most people that get COVID-19 don't die from it, but they recover. Unlike something like Ebola, where I think it was 50% of the cases that do actually end in death, we're going to see that for COVID-19, those rates are much lower. But another thing that we're trying to do is to spread out when those infections come, because otherwise the healthcare system gets overwhelmed. So if everyone goes to the hospital at the same time, they won't be able to be seen or cared for. We won't have enough ICU beds or ventilators. Whereas if we can spread out when people come to the hospital based on when their infections happen, we'll have more capacity to deal with that. The second one is, you might have heard of what's called this R0, the basic reproductive number, which is the number of secondary cases, the number of people that you usually infect if you are infected yourself. So seasonal influenza, if you get infected, you typically would infect between 1 to 2 additional people. COVID-19, it seems that that's slightly higher than flu, which is about 2 to 3 people. But we can see that something like measles, if one person gets measles, lots of other people will get it around them, between 12 to 18 people. The second one, this is a curve from Our World in Data, which is just showing the trajectory of South Africa's infections and deaths. And this graph is looking at deaths compared to the 5th day when there was a confirmed death. So those dotted lines that are going along the diagonal are showing you how many days it takes before the number doubles, basically. I think was this line. So we can see that South Africa seems to be on a trajectory, but if we compare South Africa to other countries, I've just put in some countries that other people might be interested in here as well. We started out on a very similar trajectory to South Korea. And then over about here, you can see our rates continue to increase, whereas theirs started to flatten. And our rate is likely to continue to go up quite significantly because we haven't reached our surge in South Africa yet, and there is community transmission, which means that people are infecting each other in the community. It's not like we can isolate people. So we seem to be on the same trajectory as Chile. I think everyone is familiar with how it is transmitted. So it's COVID-19 is transmitted through respiratory droplets, which that could be, you could breathe them in through the air, which is the reason why, one of the reasons why masks can be helpful, but also that you can touch a surface where those droplets are and then touch your face, which is actually much more likely as a route of infection rather than breathing it in. Because you can see that if we maintain social distance, the droplets don't actually just stay in the air indefinitely. They're more likely to settle on a surface, particularly a metal or a hard surface. Someone touches it, and because we touch our face so often, we then end up getting infected from the thing that we touch. And that's the reason why hand washing is really, really a critical intervention. And the thing to emphasize, even more than mask wearing, is making sure that we wash hands frequently.
Not touching our face and washing our hands.
And not touching faces, yes. Which is actually another reason why masks can help. It's not just not breathing it in, but sometimes when you have a mask, you're less likely to touch your face or your mouth.
If I've got an itchy lip, because then the mask is touching my lip.
I think someone might not be muted. We're hearing their itchy lip conversation. But I'll carry on. So what we can see in these two graphs here are that the one on the right is the distribution of South Africa's population. So you can see that about 29% of South Africa's population are aged between 0 and 14 years of age, but only about 5% of COVID-19 cases in South Africa are between 0 and 14. So if that's this bottom part on the left. So even though, and this is cases, right? This is not deaths. This is how many people are getting infected. And as we might anticipate, people that are of working age and moving around a lot, going to jobs, commuting, getting in taxis, moving around, were more likely to get infected, right? Now we're going to see that the death profile or the risk profile is very different to this. It's primarily amongst older people that their risk of getting severely ill or dying from COVID-19 is very, very strongly related to age, which we'll see in the next slide. But the encouraging thing from this one is that the South African evidence is conforming to all of the evidence internationally, which is showing that children are less likely to get infected, which the seroprevalence studies internationally are showing. And even when they do get infected, they almost never get severely ill, which we're going to see in a moment. So this is a graph that shows you the age groups, and these are 4 different countries: South Korea, Spain, China, and Italy, which they were some of the first countries to experience big outbreaks of COVID-19. And these are case fatality rates. So what that means is if you get infected, what is your probability of dying? So it's not what percentage of the population in this age group died. It's if we look at the age category of 40 to 49 years in Italy, for example, if you got infected and you were 45 years old in Italy, you had a 0.4% chance of dying from COVID-19. Okay. Now, what we can see here is that for older groups, for those that are 70 and 80, but even for those that are 60 to 69, the probability of dying if you do get COVID-19 are significantly higher than adults that are between, or actually anyone that's under the age of 50. If we look at this, that's less than 0.5%. But for our purposes of looking at children, notice how low the figures are for children. Very, 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 very small. So I did a calculation before. The country that's had the most number of deaths from COVID-19 has been America. And of 81 or nearly 82,000 deaths that they have had in the US, only 112 were under the age of 25. So 0.14% of all of the deaths from COVID-19 were for children under the age of 24. So it's extremely, extremely, extremely rare for children to die from COVID-19. They're much more likely to get severely ill from things like pneumonia or diarrhea, or in South Africa, things like TB or RSV than they would be from COVID-19. This is very different to most types of diseases or viral infections where children are actually at more risk because they don't practice hygiene, they touch their face, they touch each other, compared to adults. For whatever reason, COVID-19 is different. It doesn't affect children and adults in exactly the same way. So this is a slide, and I've put the link in to this is a very helpful webinar that the South African Pediatric Association hosted with pediatric infectious disease experts from South Africa who are familiar with our context. Because I think a lot of us are asking, what about, we've got much higher rates of TB and HIV. Surely we can't just be looking to what's happening in the US and Spain when we're trying to understand how this might happen in South Africa. So these are local experts. And what this shows you is that in a population, this is an adult population, over approximately 2 years, about 60 to 70% of the population will get COVID-19. We will get infected. 50 to 80% of those that get infected will remain asymptomatic. In other words, you're carrying the virus, but you're not ill. In many instances, you don't even know that you had it. You might have had a small cough, a scratchy throat, various other symptoms, but nothing that would cause you alarm or make you want to go to a hospital. Your body fights off the virus, and then you get some level of immunity afterwards. About 17 to 40% have mild self-limiting illness, where you might choose to stay home, you don't feel well. About 3 to 10% of cases, now remember this is in the population as a whole, 3 to 10% of cases that would require hospitalization or ICU. And the COVID-19 case fatality is 2.4%, and this ranges significantly based on your age. So as we just saw, if you're much older, you have a much higher risk compared to if you are younger. Okay. Now look at the same one for children. No, let's go back to this one. Can you see the dark, the one with the dark background over here, where we have, I think it says here, moderate to severe illness amongst 4.5% and deaths for 0.8%. Now, if we look at this for children, it's very different. And when we say children here, we mean those children that are 18 years and under. So it would include high schools and primary schools. The difference here is that the vast majority of children are asymptomatic when they are infected, but even when they have symptoms, they only have mild symptoms. Can you see it's only 2 out of 1,000 that actually have moderate to severe illness. And this is from South Africa's, he's an NRFA rated researcher. He's a pediatric expert, infectious diseases expert, Prof. Shabir maybe. And what he's showing here is that we don't actually have enough cases of children even being hospitalized to draw analysis. They just don't go to hospital for COVID related illnesses. That's not to say that they're not going to hospital for other illnesses that are not COVID related. Another context that's this graph is, I think, quite a helpful one. This is from the United Kingdom, and it shows you the age groups on the left, and it shows all of the people that were admitted to hospital and what happened to them. So the green means that they were admitted to hospital, but then they got better and they left. They got discharged. The orange is they got admitted to hospital and they are still in hospital. There's ongoing care. And the blue, they've been admitted to hospital and they got so severely ill that they died in hospital. Okay. And what do we notice is that this is an upside down pyramid, right? So there's almost no people under the age of, I would say, 35 in this graph that even make it to hospital. Extremely, extremely small numbers, because they don't get severely ill from COVID-19. It's not that it never happens, it's just that it's extremely, extremely rare. Whereas as soon as you start looking at the top there, 60, 70, 80 and higher, you start seeing much, much higher numbers getting to hospital and also higher deaths. So the number of deaths is clearly concentrated amongst those that are older. Now, there are big costs both to lockdown and school closures. So this is an example of the number of consultations that have happened in a private hospital network. This is the NICD that released this. And we can see that the number of consultations for inpatients, so those that were normally admitted to hospital, has gone down by at least 50%. So people are not going to hospitals to get procedures done for whatever reason. They might be afraid of contracting COVID-19, or they just avoid it. Also, TB testing in South Africa is also down significantly. So many fewer immunizations, as well as tuberculosis testing that's happening in South Africa. So I've taken an excerpt here from the South African Pediatric Association statement. So they say children biologically contain SARS-CoV-2, which is just COVID-19, it's the same thing, better than adults. They are less likely to get sick if they are infected. They have milder disease and are unlikely to die from COVID-19 and are probably less infectious than adults. Although children are at higher risk of being infected once at school, this additional risk to themselves and others is outweighed by the benefits of them returning to school. So this is the statement of the South African Pediatrics Association. So nationally, one of the reasons why having a lockdown and school closures is really costly is that the home environments of many children are not conducive to learning and are also not conducive necessarily to child well-being. So this is from the Perl study, and just showed that at least half of children in South Africa have either none or less than 10 books at home. This is primary school children. What about internet at home? The general household survey showed that only 60% of households reported that they accessed the internet on a mobile phone, and only 10% reported that they accessed the internet at home. So we can see the Western Cape rates are slightly higher than this. 26% of Western Cape households in 2018 reported having an internet connection, but it's clearly not universal. It's clearly that for many children, the idea that they can continue learning at home is not true. And what about computers? If we think that computers might be necessary to continue learning at home, only 1 in 4 households in South Africa have a computer at home. So for 75% of children that don't have a computer at home, and even those that have a computer, they might not necessarily have the internet, doing e-learning or continuing to learn like we are continuing to have a webinar is very, very difficult. And TV and radio is not a sufficient option. If you look at the timetables and schedules, it's less than 5% of instructional time. So what I wrote in the policy brief is that for at least 80% of learners in South Africa, while schools are closed, all curricular learning has stopped. And we need to accept that. It's not as if there's been meaningful curricular learning that has continued in spite of schools being closed. So I think that we need to make a clear distinction between children and adults. Yes, they can both get infected. Yes, they can both transmit the disease, but it's the virus, but it's primarily adults that need to be the focus. And I think as a principal, making sure that your focus is actually on your high risk category, which are the adults in your school, rather than the children. It's extremely, extremely unlikely that children in your school are going to get severely ill from COVID-19. What's more likely, if they are sick, is that it's some other illness. They're much more likely to be having RSV or flu or some other illness that they have that's actually not COVID, because it seems that COVID does not affect children the same way it affects adults. Whereas for those in high risk categories, more than 60 years of age, if people have diabetes, cardiac disease or hypertension, I think that there's a strong case to be made that these are high risk categories and much higher risk than normal. It's not just that, oh, well, these people are always at high risk. They are considerably higher risk than they would normally be in 2019 or 2018, okay? So I think children can also be very important vehicles for educating and passing information back to their homes and their houses. And I think that when schools do reopen, I'm sure that all of you as principals are not just going back to schooling as usual. Let's just get back to the curriculum. There's probably going to be a strong emphasis on what is the new normal? What do we do around hand washing? What is this virus? Because not all households and not all parents would have been informed about how this virus gets transmitted. There are a lot of myths. There are a lot of misconceptions. I mean, even the president of the USA is touting all sorts of nonsense around how this virus gets treated or what you can do to prevent it. And I also think that prolonged lockdowns and school closures are clearly not in the best interests of children. So what I want to do at this point, I'll just skip to this slide. I think that the unintended consequences for children, yes, there will be big learning losses. And if we think of learning losses that happen as a result of the school holidays, there's quite a lot of literature that shows the summer holidays, children forget quite a lot and they lose a lot of the learning that they have. You can imagine a similar process that's happening now. That schools have been closed. For some children, I mean, I think grade 4s are only going back in August. So the vast majority of the school year would have been lost for them, and their learning will actually be going down significantly. The lack of same-aged peers, the structure of schooling, potentially social pressures at home, parents that have lost their jobs or have a loss of income that causes increased stress in the home. It can lead to higher levels of violence and mental health issues at home, which are not good for children. Anxiety and depression, one of the studies, I think this was looking at China, found that of 2,000 children that they surveyed, nearly 20% of the kids, so 1 in 5, had depression and anxiety as a result of the lockdown and COVID-19. So I think as principals, expecting that there will be much higher levels of stress and strain and mental health issues of your students and staff when they come back, it's not going to be business as usual. And that for some children that's manageable, but for some children it might be overwhelming, and that they would need additional support and care. And then lastly, the lack of nutritional support. I think the Western Cape did a lot of very good work to continue with school feeding during the lockdown, where most of the provinces didn't manage to do that, although I think that they are trying to implement a system like that now. So Alta, let me pause there and just see if there are any question and answers. And I think if people want to raise their hands or ask questions or type questions, I'll stop sharing my screen. I can always reshare if let me just admit. I just realized I was the host. I need to admit everyone. So I think if in the participants section, if you just look at the bottom right, if you click on participants, at the bottom right, you'll see a little section there that says raise hand. And if you raise your hand, then we can I can answer any questions that you have, or you can type them in the chat as you like. And maybe I think we can also not necessarily only have questions, but you might find that you have comments that you want to make of how your school's prepared that might be helpful for the other principals to hear. If you've thought of innovative practices or heard of things that you think other principals might find helpful, I'm sure that they'd love to hear that. Jacques, you've got your hand up.
Just a question. So it looks like the kids are not that badly affected, but do we know, is there any research showing how they actually spread the virus themselves? Is there any, if you understand what I mean, is there any difference between adults spreading it and children spreading it?
Yeah, so there's less evidence on that, but what evidence there is suggests that children are less likely to transmit it to adults than other adults. So the studies that we have seem to show that there's much more transmission from one age group to the same age group. So children infecting children, adults infecting adults, rather than children infecting adults. There is some evidence showing that adults infect children in their households, and that's actually more likely. The existing evidence that we have shows that it's much more likely for a child to be infected by their adult in the household rather than the other way around. I think as teachers, though, where that's different is we're not in a household setting. And if I'm a teacher, and particularly with young children, I'm constantly having to touch them and move them and shift and or do all of the things that you're required to do when you're interacting with children. If I then touch my mouth and face, and I'm doing that all the time, it is more likely that I'm going to get infected compared to if I was sitting at home by myself. But this is where I think that communicating to teachers that they are not at more risk of being at school than they are at home, as long as they are practicing social distancing, washing their hands, and wearing a mask. It's not as if this is just buzzing around in the air and that because we're at school, like they're much more likely to get infected. If we can practice social distancing, wash hands, and wear masks, it's a lot of people are saying schools are actually much safer than most working environments because there are fewer adults. And if we think that adults are actually the big kind of the main people that are infecting other adults, then being in a bank where you've got 20 or 30 other adults around you in close proximity may actually be at a higher risk than if you had 100 children at a school, for example. So I hope that answers your question, Jock. And the exact reason why is not totally known. Some of the explanations are actually really quite sweet and cute. The one is just that children are short. So children are shorter than adults. So their kind of environment is actually just different. They're operating at a lower stratosphere compared to adults that are higher up. And another quite cute explanation is just that they have much smaller breaths. that when they breathe out, they don't actually breathe out as much air and respiratory droplets as adults do. And they're lower down, so they're more likely to fall to the ground rather than be spread more widely. There are also medical explanations that their lungs have fewer ACE2 receptors, which is what the virus needs to get inside the lungs. And the last explanation is that the children actually have a lot of other coronaviruses that are already in their system. COVID-19 is not the only coronavirus that exists. It's just one of many. And other viruses are competing for space within our respiratory system, and that competition is higher in children than it is in adults. And as a result, the COVID-19 is not as severe in children as it is in adults. But all of these are hypotheses. We don't yet know for certain. The only thing we do know for certain is that children don't seem to die and don't seem to get severely ill. Now we're just trying to figure out why.
Thank you very much. Being 1.9, I feel quite a bit safer now.
So I don't know if there are any other questions. Just remember to unmute yourself before asking your question.
Can I?
Yes.
Hi, I'm Terence Klaassen. I'm here at Fairmount Secondary School, and we service largely the Parkwood Lotus River community where TB is extremely high. I've had questions from matriculants who suffer from asthma and that's on nebulizers. I don't know how nebulizer work. And so one of the questions was from the parent, can I send the nebulizer to the school for my child? And again, research has shown that it's not a good idea because I don't know how nebulizer works, the actual operation. But it was said that if the nebulizer is in a particular area and the child is infected, that you're actually spreading the virus by using the nebulizer. So the advice in those 3 studies said that rather let the person be excluded from the rest of the school. That was the one thing. The other thing was yeah, I'm glad I'm 1.5, so I'm in the middle there, and not in the heights. But my concern is, you know, it's like smoking. You know all the bad things about smoke. It's not good for you, and all of that kind of stuff. We find people smoking. So the same thing with the virus. The fact that you have this knowledge that you just divulged to us about the AC receptors and so on. The fact that you have that knowledge doesn't take away the fear and the anxiety that teachers are experiencing. And then teachers are not on their own, and I'm sorry I tuned in late. Teachers are not on their own. I mean, they've got their families at home, spouses that are comorbid, or family members in the same household that's comorbid. So the fear is, yes, the child could be asymptomatic, but the child could be bringing the virus to the school. I get infected as a teacher, I take it home. My wife is a teacher, she takes it to her school. My dad is in the house, he's hypertensive and diabetic. So, you know, all of that kind of stuff. And today they were told that, you know, I was told specifically, I didn't want to be the one that would have brought the virus to Fairmount or to take it from Fairmount and take it out, you know?
Yeah.
So
no, I think these are very real. I think these are very real concerns, and not ones that we should treat lightly at all. I think that it's not only teachers that are going back to their households, but also children that might be taking it back, even though it does seem to suggest in places where they have reopened schools, it doesn't seem that children are taking the virus back and infecting their parents at much higher rates than their parents would be exposed to in any other environment. But it is possible, right? And particularly if you have a gran or a very elderly person, or someone that's diabetic or has hypertension, as you mentioned, that happened a lot in Europe, where they have multi-generational families of very old people living in the same household as working adults, that you don't want to be the person that, you know, caused your family member to get ill, severely ill, or die. On the asthma question, there is actually quite a lot of discussion about that. And I think that if you have asthma and it's well treated and kind of normal, regular asthma, you're not at high risk at all. That's my understanding. But it sounds like in severe cases of any of these pulmonary illnesses or lung diseases, then you need to be trying to get a specialist medical opinion, which it sounds like you did have, this question of the nebulizer. But if you've got parents from children that are saying, you know, my child is asthmatic, does this putting them at high risk? No. there's no evidence that says that children that have well-treated asthma are at higher risk. In terms of what to tell teachers, I think that what you've said is correct, that I think everyone has fear around this, and only by trying to share information, and particularly information from authoritative sources, so things like sharing the newsletter, that newsletter of the South African Pediatric Association, or the webinar link that I'm going to link in here, which the South African Pediatrics Association did, or other material that you find to be authoritative, particularly from medical professionals, right? Because I'm not a medical professional. I'm an economist that looks at education policy. The only reason why I'm exposed to this stuff and know is because schools are closed. So we have to look into this to try and understand what is the science saying around this and who is at risk. But I think finding a way of identifying which teachers are at special risk or special high risk, and in trying to come up with plans that mitigate that risk, whether it means that they are, not facing the front, or if they're staying at home. But teachers that are older than 60, those that are diabetic, those have hypertension, I don't think we should be treating them in the exact same way as we should be treating a 25-year-old teacher who's at almost no risk of getting severely ill themselves. And maybe this is where we also need to get innovative. This is not something that's within your control, but something I've said to the department is, I don't know why they don't get fourth-year teachers who need to be doing their teaching prac to temporarily come into the schools and take over for the next 6 months or a year from teachers. Because if 20% of your staff aren't able to come to school, who must be taking care of the kids that they're meant to be teaching? We don't have 20% reserve teachers that are particularly low risk reserve teachers. And also who's going to pay for those teachers? Because that's a lot of money that the department doesn't have. So I think coming up with creative solutions of finding particularly young teachers to be locums for this period, I think makes a lot of sense.
Thanks very much.
Sure.
Nick, can I ask you a question? It's
sure.
Just about if you were suddenly catapulted into being the Minister of Education, what would your plan be for relaxing, for allowing the other grades back to school? Do you think the plan we have is a good plan, or should they come back quicker or slower? And then the other question is, if you were the chairperson of the COVID-19 Command Council, what would the perfect plan be for releasing the lockdown and relaxing to other levels? When should we be? Okay. When should backing off?
Sure. So I think that on the question of schools, I agreed with the idea that we needed to close schools and do a lockdown at the start of the COVID-19 outbreak. There were so many unknowns. No one knew how it worked. Children are generally seen as vulnerable groups. We needed to do it, right? Now that there is much more evidence showing that children are at much lower risk, and particularly young children, I think that after about 4 weeks of lockdown, we should have ended the lockdown almost completely, not gone 5, 4, 3, 2, 1. We should have just gone straight to level 1 with very strong messaging around social distancing, wearing masks, staggered times. And I think that the authoritarian, or the much more, the strong arm of the state, which is currently being exercised in things like curfews and lockdowns and no alcohol and no tobacco, should have rather been administered as in 15% of the space of all billboards and all newspapers and all television ads should have been, are you practicing social distancing? Are you washing your hands? So we bombarded with that message, but allow kind of everything to keep going until our surge happens, which was only scheduled to be August. If we did this, it probably would have been slightly earlier. But there's a misconception in the public that you can stop it happening, which is not true. You can't, it has to happen at some point, right? Unless there's a vaccine, if a vaccine came tomorrow and we all managed to get it, then we could avoid it entirely. But until a vaccine comes, the solution is at some point enough people get infected that we stop infecting each other. There's this herd immunity. That only happens over 2 or 3 year time frame. So I would have ended the lockdown. I actually think in the Western Cape, unfortunately, we are sort of in the worst position, because just as we're reopening schools, the surge is about to happen. So if the surge happens in the middle of June, this is when there's going to be 2 grades that have just come back. And I suspect that when hospitals are really not coping, and we're seeing all of these very dramatic media stories around people dying and not enough ICU beds and the ICCs overflowing and, you know, all of these types of things, it's going to be very difficult for the provincial ministers to say, let everything stay open, more grades must keep rolling out. Do you know what I mean? I suspect that there's going to be a scaling back, or in other words, back into lockdown, and saying, no, schools need to close again, only to reopen after now, whether that's the right decision is a different story. There are lots of reasons why school closures can hurt lots of things, including if you are a nurse or if you're a doctor and you have children that normally get care if by going to school, what happens to them when everything is closed down? On the question of the Ministerial Advisory Committee, so I'm on the Ministerial Advisory Committee subcommittee on reopening schools. And there was a advisory that we wrote to the Department of Health, which I don't think I have it in this presentation, but the gist of it was schools need to reopen as quickly as possible. This is in the best interests of children. The longer that they stay shut, the more costly this is for children on a number of fronts. And it just doesn't make sense to keep schools closed. The problem with the method that we're implementing at the moment, let's take nationally, we're rolling in grade by grade. I think grade 4s end up coming back in August. When is the surge meant to happen? In August. So if I'm a grade 4 student, I haven't been in school since March. I'm meant to go back in August. Schools shut down again. I don't go back in August for another 3 months. I've basically lost this whole academic year. Now, those sorts of disruptions, I think we actually are going to see things like higher dropout rates, children not coming back to school, particularly high-risk children, and a number of those sorts of problems that up until now we haven't thought of as being problems. We're like, everyone is coming to school, dropout is concentrated in grades 9, 10, and 11. Whether that's a given going forward, I don't know. And then on the lockdown more generally, I think that they should have ended it quite severely. I don't think that the idea of moving through these stages helps anyone. I think that what we needed to do was get kind of as much economic activity going again with proper social distancing, hand hygiene, staggered times, all those sorts of things, with the aim that we lock down when the surge does actually come. The problem is, I think that we've used I don't want to say we've used too much of our ammunition, but like we've almost went the nuclear option early, which is shut down and stay shut down for 8 weeks. And there's been an implosion in economic activity, and that can't be topped up with government grants. Government grants compared to market income don't compare. The upside is I think that this is now also seen as the prevailing view within government, which is the reason why everyone's like, yeah, infections are going up, but still, it's fine. Let's open the economy. Let's go back to school. The other thing you might have heard about, which is worth emphasizing here, is that the World Health Organization has 6 conditions in order to come out of lockdown. Some of you might have heard this, and that we don't meet these conditions because our infections are not going down. The problem is that those conditions were actually specified for mainly high-income countries that already had their surge. So they went into lockdown when their surge happened, right, which is when their peak infections are happening. And they were saying you can only come out of your surge when your infections are going down. Now, we haven't got to our surge yet, so the infections are never going to go down. They have to keep going up until we get to the top of the surge, and then they can only start coming down. So in a way, if we follow that logic, we shouldn't ever leave lockdown until our surge comes, which we think is coming perhaps in August. And that's just not feasible. So I think that particular instruction or advice was actually given for a context that's different to us, because those countries didn't lock down at such an early stage compared to us. I'm also quite interested to hear, I mean, are there any other innovative solutions that you guys have found or read about or heard about that you're planning on implementing at your school, whether practical or profound, either? Yeah.
I look at our school, like I said, our average age, my teacher's average age is 53. So we've got 11 of them out of the 26, I've got 11 of them with comorbidities. And so we find extreme difficulty in appeasing people as far as safety is concerned. So what we've decided, we eventually decided to go the rain suit route, and you have the mask and you have the visor, the head visor, and some people are even having a see-through curtain. So you come in, there's a two meter space between the board and the first row of learners. So you have a see-through curtain as well. So and people have got, they come to you with those fears. What if I'm the person that's taking it out? And so you want to avoid that as far as possible. And so what they've done is they've now decided, fine, we have these we desanitize before we go home. Take off your rain suit, desanitize the rain suit, leave the rain suit at school, go home, get undressed, go through the baggage, to the from the back,
Yeah.
So, but I mean, and then also we have a funder that has come on board that's supplying the shields. Besides the face mask, we got supplying shields for the grade 12s as well. So we're trying to put and then obviously practicing the distance, social distancing, physical distancing. So for the grade 12s, it's perfect. It works perfectly. But just to get them into that routine of separating and not having seen each other for 8 weeks. So now all of a sudden we want to get together and chat. So that has been, we're marshalling that. So that has been working fine so far. So possibly on Monday they will be in that routine of no movement from class to class when they do have to move, and also during breaks. So we've got that down to a pat. So it's just one of those things where we of shields. I said, even if I can put on double shields, people put on double shields to protect the guys. And then it's also a story about the heart and the mind. Your heart is telling you, I have to be here for these kids. Many of them are in their families to get to matric. So you want to help them break that cycle of poverty. And so your heart is saying, yes, I need to be at school and I need to assist these kids to get through grade 12 this year. Because if that doesn't happen next year, it's not going to happen. They're going to have to go to work if they can find work next year. They're not going to go to school. So your heart is in the right place, but your head, your brain is telling you, listen, guy, you've got these comorbidities. Your parents have got these comorbidities, so is this the right place to be? You know, so you have that autonomy, that fight, that contestation happening all the time.
I also think if you're in a context or community where there are high rates of TB, given that we've seen this decline in TB testing, I think something that's probably advisable is to just encourage whatever that procedure is that normally would lead to TB testing, that people don't get tested because they're afraid of going. Do you know what I mean? Because at least for children, but I suspect for adults that are under the age of 60, not getting diagnosed with TB and making sure that you are ongoingly having your medication and don't have a break in your the medication that you're taking is also really important to emphasize with them.
Thanks. I'll pass it on to the parents as well. Thanks very much.
Cool. The one thing I hope no one is doing, these spray tunnels. There was talk of the spray tunnels. These are really bad. They're bad for children. They are bad for their eyes. They're bad for their nose. Like, you need to throw it away or resell it back to the people that sold it to you. They're really, really, really terrible. The one other thing that might be worth emphasizing, which hasn't come through strongly from the department's guidelines, but the Ministerial Advisory Committee did say this, is that temperature screening. So, you know, the pointing the temperature thing is actually very not a helpful measure when trying to spot COVID-19. So they don't actually, the Ministerial Advisory Committee doesn't advise using temperature checks to try and identify COVID. The vast majority of people, and particularly children that are asymptomatic, are not going to have fevers. And if you do spot someone with a fever, it's probably not COVID, it's probably something else. And where they know this from is that when they did most of the temperature screenings at OR Tambo, as soon as the virus came, not one person that was identified that had allegedly had COVID-19 because they had a higher temperature actually did or tested positive. And yet all the cases came through OR Tambo, right? We know that they flew in, so they weren't spotted through the temperature scans. So there's no evidence that shows that temperature scanning children at the start of the day is somehow identifying children at higher risk. Just on the one about children, I think I'm involved much more with primary school children because my interest is also on early grade reading and early grade maths. I think managing the psychosocial needs of these children, particularly young children that don't understand what's going on. I mean, I'm just thinking of the shower curtain and the multiple layers and visors and protections and whatever. The perception as a child, you can imagine the stigma of like, am I infected? Is there something wrong with me? Like, why is everyone like running away from me? I'm told, don't touch your friends, stay away from your friends. You can't, your friend might be infected with a disease that might kill you, and that, you know, the weird messages. That's really not good for children's own like mental health and their sense of self-concept and peer support that they need. And I think the younger the child is, the more confusing this is. And I think that we need very strong, clear, creative, innovative ways of communicating with kids, whether it's like doing projects or messaging. I don't think we should just carry on with CAPS as per usual. I think we need to find a way of saying, what are creative ways that we can make sure kids understand what's going on and that we're all on the same page and that they don't have this anxiety or fear around the virus and are informed about how to actually protect themselves and their families. Okay, is that a wrap? I mean, Alta, I will forward this PowerPoint to you now. You can feel free to share it with everyone that's here if they think it's helpful, or anyone else in SAPA. And obviously the recording you're welcome to. And then if I find new and interesting stuff, I just put it on my blog, which is just nickspaull.com. There's also an interview with a pediatric infectious diseases expert who summarizes some of this evidence as well. So yeah, but hopefully it's been helpful. And I think the more people that are aware of some of the science and the evidence about what's going on, the better. And that we, you know, wherever we don't have knowledge, there's fear and superstition, which is not going to help us. What's going to help us is understanding what's going on and doing our best to kind of implement the measures that we think stop the spread of this virus.
Yeah, so perhaps just Nick to say that we really appreciate the time given to us and the wealth of information shared today. It will definitely impact my practice, and I'm sure those that joined us today will look at what we are doing in a different light, in the best interest of the children that we serve and the communities that we serve. So thank you very much for the time, and thank you everybody for joining. We will share whatever Nick shares with us and the invitation to visit his blog. Some very good information that you can access there as well. Thank you. Have a good evening.
Great. Thanks a lot.
Thanks.
Cheers, everyone.
Thank you. Bye-bye.
Bye.
See, Kay, I'm coming in.